The particular challenges in foot and ankle surgery pertain to the anatomical shape of the bones, and that's not just unique to the foot and ankle, but it's also unique to the hands because they're abnormal shaped bones. They're curved surfaces, flat surfaces, saddle-shaped surfaces, all trying to move in numerous directions. And so the options when you're fusing that is you remove the articular cartilage, you put two flat surfaces together, but by doing so, you shorten the bones and that changes the shape of the foot. And so we don't like to shorten the bones. So what we typically do is prepare the surfaces with two abnormally shaped surfaces. When you put them together, you leave bone voids, and those are the spaces that we would normally put bone graft into. In particular, also, the forces going across the joint are slightly different. So, for example, in the spine, it's typically a compressive force going up the spine, an axial load, whereas in the foot and ankle, it'll be a shear or rotatory force. And I actually have had spinal surgery myself, and I wrote to the surgeon, I found this out 10 years later, but I specifically wrote into my letter, I'm in a corset and I'm fine from flexing from side to side, but I'm not from rotation to rotation. I was twisting and turning at night, and I ended up developing a non-union. So I've personally experienced that rotatory forces can, I think, significantly affect bone healing. A nice CT-based study suggests that there are problems with non-union. So these are the bones not knitting after this type of surgery. And the risk of that in the paper suggested about 21% overall rate of non-union. They looked at all papers that are out there, many of them being low-level studies, level 3 and 4 studies, but you can't ignore the fact that this is a challenge in orthopedics. Now, we ran a large randomized controlled study looking at the hindfoot, so this is the ankle fusion versus ankle replacement study, and in that study, looking at the fusion patients, about 12% didn't unite, so 12% of patients still didn't have union at 12 months on an X-ray. The rate of revision surgery was about 8%, so that's probably the risk of in a real-world study, the risk of a non-union. There are many factors that dictate the risk of non-union. Surgical factors, so it's really important in fusion surgery that you remove all articular cartilage, you put two bony surfaces together, you either hold them or compress them if you can, and in many cases we may or may not use bone graft to fill any voids and to assist with the fusion. Now, there are certain patient groups that significantly affect those fusion rates, and those patient groups perhaps explain the high risk of non-union. In those groups, it may be much higher than 20%, and those include diabetics, smokers, people that are non-compliant with treatment, people with low vitamin D. And I think in those patients, a bone graft certainly can help augment further healing. Whilst 20% is the overall incidence of non-union in the foot and ankle, within that mix, there'll be patients that have a 1% risk of a complication, and there'll be patients that have got a 90% risk, and we're good at sort of identifying which patients we think are higher risk patients. Now, there's two variables that will dictate the outcome. One is the biomechanics, and as surgeons we're extremely well trained at dealing with how to do the surgical side, the fixation side. We're less well trained, if you like, how to deal with the biological side. There are things that we can do preoperatively. We can optimize the patient as much as we can. We can give them vitamin D supplementation, enhance and manage their diabetes, tell them to stop smoking, put them on a smoking cessation program. But the reality is that we often need assistance, and that's where the role of biologicals, I think, has an important role.